Okay, in this short presentation, we're going to deal a little bit with crown troughing with the new Picasso light diode and eliminating cord. There are many different ways to crown trough in many different settings. And I typically use 0.7 watts continuous wave to 1.2 watts continuous wave. Now with the Picasso light in the posterior, you could use the rabbit setting, which is 1.8 watts continuous wave if you want to be faster. And if you're not in too much of a rush, or if it's a highly aesthetic area or a patient with very thin tissue, you could use the comfort mode, which is preset to 1.8 watts pulsed. Now in general, I can use gated pulse at lower settings with the microscope at 1.4 watts to 2.4 watts. And again, the preset on the Picasso light is set to 1.8 watts. Depends on the location. I'll use less in the anterior and more in the posterior because I'm less concerned about recession in the posterior, whereas in the anterior it can be a crucial aesthetic issue to the patient should the cementum of the tooth be exposed due to a slight amount of recession. If I'm using topical only, stronger topicals like Cetacane or TAC20, Tricane Blue, perhaps if it's an endo-treated tooth, then I typically will use in the 0.7 to 0.9 watts continuous wave, or again pulse settings of 1.4 to 1.8 watts pulsed. These are settings that you can often use without anesthetic, injectable anesthetic, and get away with just topical. I use less for any patient that has very thin tissue, thin genotype, and if you're concerned about recession. And again, less for inflamed tissue compared to fibrotic tissue. If I take off an old crown and the tissue is quite inflamed, I typically can get away with less anesthetic, or sorry, less in terms of settings than if the tissue is very fibrotic and very white in color. Finally, after the initial trough is done, if I require to have some expansion, some lateral distension of the tissue to get a clearer view of the margins, Expasil or Traxident are great products. Expasil is a little bit thicker material, and they can be placed into the sulcus. They do a good job with hemostasis for any time when there's a little bit of oozing. This classically occurs in patients who are on Coumadin or blood thinners and may require a little bit of extra hemostasis. Expasil or Traxident, which is a lighter product, work great. Here's a clinical case where the upper right first molar, the porcelain crown there, has been fractured. Patient has an aesthetic concern with metal margins showing and required this particular crown to be replaced. You can see an occlusal view on the right hand side here, and on the left hand side you can see a buccal labial view. The crown was anesthetized. The patient was anesthetized with articaine, and then a rubber dam was placed over top of the crown in question. You can see a vertical groove was cut through. One of the nice things with working under the operating microscope at various magnifications of between 2 and 20 power is the documentation capabilities, and secondly, clinically, you can see here that you have a good view of the cement and the metal. You can avoid a deep gouging of the tooth structure because you know exactly when you've cut through the porcelain crown. Here's a high mag view at about 13 power of the cut made through the porcelain with a diamond and then through the metal with a carbide burr into the cement. This is pried apart, and after removal you can see the core of the tooth is fairly dark in coloration, and these are the ones that used to be of quite a concern until with high magnification you get a little bit better view of where there is decay, which was in this case on the distal and also on the lingual, as you can see on the right hand side. Now the tooth was cleaned up, prepared with a diamond, and then air abrasion was used, and we put a core buildup in the tooth, and you can see on the left hand side here core buildup. Now in this video you're going to see the Picasso light with one of the older handpieces, is gold in color, used, and it is used in this particular case at roughly 0.9 watts continuous wave. Now one of the things I tell people to do is when you're concerned with whether you're cutting or not, leave the tip on the tissue. And if you notice it isn't cutting, then I went to the other side. You can initiate it in the blood, and you can see there it just initiated a little bit on the mesial, and now I get a much better cut. you leave the tissue, the diodes just straight. There you go. And now you see a little bit of a plume, and you know that you've initiated the tip. You're ready to go. I've raised the magnification here to about 8 times magnification, and I go in short brush strokes. You can see I have approximately 2 to 3 inches of fiber out of the end of the cannula, metal cannula, and I'm going constantly in short brush strokes, angling towards the tooth. The intent is not to create a deep trough, but to laterally distend the tissue a little bit, and thereafter be able to distend it more with, in this case, we did Traxident. So I do short brush strokes, and when the tissue builds up onto the laser, as it is here, you stop, have a wet gauze, and clean off the tip in a simple fashion. Have the assistant clean off the tip, just pulling with the gauze so that you do not cause a break in the fiber itself. You can see every once in a while that I get a little bit of a tissue tag, and we're now going towards the mesial. Again, you can see the amount of fiber that is extruded. If you look, you can see the metal cannula, then the Teflon or the coating on the fiber, the cladding, the insulation, and finally the last little bit of the fiber that is exposed with the initiated tip. Again, you can see that you're not getting any bleeding. In fact, we've stopped the bleeding that was happening on the mesial after the crown was cut off because of the deep preparation. And we're now going towards the palatal aspect, again in short brush strokes. The whole process takes roughly 2 to 3 minutes of time. And one of the nice things is, unlike cord, should the impression not work out the first time, you don't have to go back and repack the cord. You can actually take another impression without worries of the tissue flopping back into place. It's not easy to hold the mirror steady to show you exactly what's being done with the diode, but you can see in this particular case that we're now coming around to the distal lingual corner of the tooth number 3 or 1/6 in the international numbering system. And we're just about complete in terms of the initial troughing. Now, a lot of times after the first pass of the diode laser, what I'll do is I'll go and refine the margins so that I'm equigingival or slightly subgingival, particularly on the buccal where I'm concerned about the aesthetic show of this area, and remove any tissue tags. Now, there's a number of ways you can remove tissue tags. You remove them with a wet cotton pellet, with hydrogen peroxide in an ultra-dense syringe. You can remove them with a sonic cable flex, which will also remove it. Any of these methods can remove the tissue tags that you see there. You'll find that with the diode, you're not only creating a trough, but you're conditioning the tissue as well. Now, some people feel that they're far faster with cord, and you can be far faster with laser too. If you want to use high wattage, you can use that. But again, for me, there's always a worry about should recession occur with the laser. So you can see there's the initial troughing that's been complete, and now what we'll have done is we put some Traxident into the tissue, push it down with a wet cotton pellet so that you get some hemostasis, and in addition you get some slight lateral distension of the tissue. On the right hand side you can see the preparation and diode tissue troughing that's complete. You can see a fairly nice looking tissue, which with the low settings that I used is not going to cause you a lot of charring. It may take you a little longer to complete the process, but to me the speed is not the issue. It's doing a good job, and secondly, not creating a lot of postoperative sensitivity or recession. The impression is taken, and you can see on the right hand side the impression, and it gives you a clear view of the margins at high magnification, and the patient then is provisionalized and will be sent away. So I want to finish with that particular case, and this is a second case, and I'll deal with this one in a later movie for you. This is Dr. Glenn Van Ass saying, keep lasing, it's amazing.